Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Daniel Reynolds. Today's episode is on the burden of skin and soft tissue infections, epidemiology, clinical presentation, and diagnosis, featuring Dr. Martin Krsak, who is an associate professor of medicine in the Division of Infectious Diseases at the University of Colorado School of Medicine in Denver, Colorado. Listen as he provides background and context on skin and soft tissue infections, including epidemiology and economic impact, clinical presentation, distinction between purulent and non-purulent infections, and complications that should be ruled out prior to treatment. This episode is taken from our series, Lose the Line, the role of long-acting lipoglycopeptides in treating acute bacterial skin and skin structure infections. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Krsak.
Hello, everybody. My name is Martin Krsak, and I'm on faculty at the University of Colorado School of Medicine with the Division of Infectious Diseases. Today, we will be talking about the burden of skin and soft tissue infections, their epidemiology, clinical presentation, and diagnosis. As a case study, we have a 43-year-old woman who represents to the emergency department with a 4-day history of redness, swelling, and pain of the right lower extremity. Her temperature is 38.2 degrees Celsius. Her heart rate is 85 beats per minute. Her respiratory rate is 18 breaths per minute. Her blood pressure is 115/74 millimeters of mercury. White blood cell count is 11.5. Serum creatinine is 0.79 milligrams per deciliter. She is HIV negative via an antigen and antibody screening test. She's hepatitis C antibody negative, and her hemoglobin A1C is 8.5%. She was prescribed a course of oral antibiotics 2 days ago, but never picked them up. Her physical exam shows 8-centimeter area of redness, and the skin resembles an orange peel. There's no induration or fluctuance, and there's an appropriate response to pain on palpation. There's no known trauma to the area or past surgical history at the site. Her past medical history includes diabetes mellitus and a bipolar disorder. Her social history shows that she has difficulty maintaining scheduled appointments and is currently unhoused. Her current medications include metformin and insulin, but she appears to be non-adherent with these. She does not have any known drug allergies. So how would you classify these patients' skin and soft tissue infection? What's the type and severity? What is the most likely underlying bacterial etiology? So let's talk about the epidemiology. Skin and soft tissue infection rates are discrepant between a number of studies, unfortunately. However, a retrospective and observational cohort study of the United States claims data in a stratified complicated versus uncomplicated infection by Miller in 2015 showed that the SSTI incidence, as measured by episodes per 1,000 person years, was around 50 for any skin and soft tissue infection episode. And of those, about 27 to 28 included uncomplicated, and the remainder of around 20 was complicated. In a retrospective single-center study in Chicago of outpatient and emergency department encounters based on diagnosis code, and this was stratified for adult versus pediatric encounters, we see incidence per 1,000 encounters on the graph in the right. The blue line represents the overall rate, while the red line and the green lines are pediatrics and adults, respectively. This study assessed patients from the years of 2006 to 2014. As you can see, while in the study on the left, the rates were fairly steady, it appears in the study on the right that they may have been slightly decreasing. The good news, however, is that the clinical outcomes, such as the skin and soft tissue mortality rates, are improving with advancements in care. This retrospective cross-sectional study analyzing the United States discharge data shows that while admission rates went up between 2005 and 2011, the mortality rate went down. Let's compare the economic impact of skin and soft tissue infections versus other infections. This is from a retrospective cohort study of the administrative claims, which we presented before. And the diagnosis codes for skin and soft tissue infections were compared with urinary tract infections and pneumonia. As we can see, the skin and soft tissue infections in a blue line, as measured by incidence of episodes per 1,000 person years, are significantly higher than both of the other diagnoses. The urinary tract infection diagnoses are presented in a similar incidence of episodes per 1,000 person years in the orange line, while the pneumonia is presented in the green line. Overall, it appears that skin and soft tissue infections were 2.5 times more frequent than urinary tract infections and up to 10 times more frequent than pneumonia. More on the economic impact between the years of 2000 and 2012 from a national population-based study from Medical Expenditure Panel survey. There was a threefold increase in direct healthcare costs driven mostly by ambulatory expenditures between the year of 2000 and 2012, and total population-based antimicrobial prescription rates for SSTIs increased fourfold from 2000 to 2012, and that is specifically from 59.5 to 250.4 per 10,000 persons. Regarding the etiology of skin and soft tissue infections, on the right side, we can see a graph with the distribution of pathogens among hospitalized patients with culture-positive complicated SSTI treated with appropriate or inappropriate empiric therapy. The inappropriate and appropriate empiric therapy are color-coded, with inappropriate being in blue and appropriate being in orange. Most typically implicated are Staphylococcus aureus and beta-hemolytic streptococci. And these represent about 80% of culture-positive infection. Community-acquired methicillin-resistant Staphylococcus aureus is also implicated in patients who lack classic risks. Less frequently implicated are gram-negative organisms, anaerobes, yeast, and polymicrobial mixed infections. However, these then contribute to inappropriate choice of too narrow empiric antimicrobials. So what's the impact of inappropriate antimicrobial prescribing for hospitalized patients? In this table, we can see a summary of 4 studies and the population describing their diagnoses and the percentage of patients receiving inappropriate therapy in the third column, and the burden of outcomes is what we can see in the fourth column on the right, which includes additional hospitalization days needed, additional days of antimicrobial therapy, and additional incurred cost. The clinical presentation of skin and soft tissue infections includes erythema, swelling, warmth, induration, pain, and or tenderness to palpation, and a draining wound may be present as well. These local signs may be accompanied by signs and symptoms of systemic illness, such as fever and or chills, diaphoresis, malaise, and the patient may have various elements of systemic inflammatory response syndrome criteria. Now I'm going to introduce another term, and that is acute bacterial skin and skin structure infection, or ABSSSI, which is an FDA definition, or the U.S. Food and Drug Administration definition, for enrollment into clinical trials. And it does substratify abscesses to those that have an estimate of at least 75 square centimeters of surface area. Otherwise, there are no major differences between the definition of ABSSSI and SSTI, as in skin and soft tissue infection. And therefore, these terms are often used interchangeably, both in the literature as well as in clinical documentation. For ABSSSI, there's cellulitis or erysipelas, which is a diffuse skin infection characterized by spreading areas of redness, edema, and or induration. These are so-called nonpurulent SSTIs or ABSSSI. And then there are purulent ones, which are wound infections. And those would be purulent drainage from a wound with surrounding redness, edema, or induration, or a major cutaneous abscess, which is a collection of pus that's currently not draining and is located within the dermis or deeper and is accompanied by overlying redness, edema, induration. As far as the severity classification for purulent skin and soft tissue infections, these include furuncles, carbuncles, and abscesses, and could be mild with no systemic signs of infection, moderate with systemic signs of infection, but hemodynamically stable, and severe, which failed incision and debridement plus oral antibiotics, or have multiple systemic signs plus acute hypotension or organ dysfunction, or are immunocompromised, or are present in an immunocompromised host. The systemic signs of infection include temperature over 38 degrees Celsius, tachycardia with a heart rate of over 90 beats per minute, tachypnea of respiratory rate over 24 breaths per minute, and abnormal white blood cell count of over 12,000 or less than 400 cells per microliter. Similar severity classification for non-purulent SSTIs, again, mild is with no systemic signs of infection, moderate systemic signs of infection, but hemodynamically stable, and severe meet the criteria when they failed antibiotics or have multiple systemic signs of sepsis or septic shock, or are immunocompromised, or perhaps have signs of deeper infection. And these are typically caused by streptococci in the vast majority of cases. Let's talk about the role of incision and drainage versus antimicrobials in the management. For purulent skin and soft tissue infections, incision and drainage is the mainstay of therapy. Antibiotics may be used in conjunction with incision and drainage for patients with systemic signs of infection or situations where incision and drainage may pose more risk than benefit. Role of antibiotics in mild and small abscesses, which is typically less or equal to 5 centimeters in diameter, is uncertain, unless, of course, the abscess is undrained, in which cases we do not have any other options other than to use antibiotics. For non-purulent SSTIs, the primary treatment is the use of antimicrobials for all severities of cases. There are important complications that need to be ruled out during the evaluation and prior to treatment, because these would specifically change the course of therapy and or its duration. And these are necrotizing fasciitis, osteomyelitis or septic arthritis that's underlying the SSTI, the presence of tenosynovitis, bursitis, or myositis, which may drive a need for a longer use of antimicrobials. We also need to rule out the presence of underlying hardware, which may be infected, and assess for decubitus or other types of chronic ulcers, which may be unlikely to heal and therefore may need to be managed on an individual basis based upon response. And then also, we need to be sure that we are not dealing with a concomitant bloodstream infection and or endocarditis or other deep-seated areas. As far as distinguishing between non-purulent cellulitis from necrotizing fasciitis, so non-purulent cellulitis may have an obvious sign of trauma, recent surgery, or ulceration, but often small breaks in skin are clinically unapparent at the time of presentation. In necrotizing fasciitis, the outlook may be the same on the outside. As far as the systemic signs of infection, in non-purulent cellulitis, the patients may or may not meet the systemic inflammatory response syndrome criteria. In necrotizing fasciitis, the presence of a SIRS criteria plus more advanced clinical picture is much more frequent. On physical examination, the non-purulent cellulitis may have an appearance of an orange peel or can just be red, smooth, and warm. The subcutaneous tissues are palpable and yielding, and the pain is what we would call proportional to the clinical picture. In necrotizing fasciitis, there may be a developing compartment syndrome in the limbs, especially with wooden hard induration of subcutaneous tissues, and fascial planes and muscle groups may not be able to be discerned by palpation. And the pain in these instances tends to be out of proportion, even without touching the affected area. And the tenderness is that much more prominent. As far as bacteriology, in nonpurulent cellulitis, we're mostly dealing with group A streptococci, but also other groups of bacteria mentioned before. And in necrotizing fasciitis, it is the same. It could be group A streptococci alone, but often it can be polymicrobial, and there could be involvement of anaerobic bacteria and gas-forming organisms. So to revisit our case study with our 43-year-old woman who represented to the ED with a 4-day history of redness, swelling, and pain in her right lower extremity. As we all remember, she was mildly febrile, but otherwise stable. She did receive a prescription for oral antibiotics 2 days ago, but never picked them up. She has an 8-centimeter area of redness, and the skin resembles an orange peel, but there's no induration or fluctuance, and there's an appropriate response to pain or palpation as expected. She is currently unhoused and has a poorly controlled diabetes as well as a bipolar disorder, and she's not adherent with her medications, and she does not have any known drug allergies. We are supposed to assess her type of SSTI and its severity. So how would we classify this patient's SSTI and its type and severity? So this would be a presentation of a moderate non-purulent cellulitis. And what is the most likely underlying bacterial etiology? So in this case, it most often would be streptococci, and specifically group A, or Streptococcus pyogenes. For the key take-home points, we should mention that skin and soft tissue infections represent a significant burden on the healthcare and are among the most commonly encountered infections in the emergency department and a frequent reason for ambulatory visits. We have to rule out complications, as discussed before, to prevent treatment failure and poor outcomes. And we should be distinguishing between purulent and non-purulent forms in order to determine the appropriate management. Again, for purulent, Staphylococcus aureus or mixed flora is often present and can benefit from incision and drainage with culture to determine the extent of the microbiology pathogens. In non-purulent, it is often streptococci, and antibiotics are the critical part of management.
Thank you to Dr. Krsak, and thanks to the listener for joining in. To listen to more episodes in this series and to see slides on burden of skin and soft tissue infections, see the links in the show notes. Thank you and have a great day.